Sir, you can please go ahead, sir.
Actually, can I start?
Yes,
Yes,
sir.
sir.
Please.
Yeah, thank you so much. So this is regarding the cadaveric brachial plexus as discussed and informed to the coordinators. I will be sticking only to the superficial cervical plexus, the interscalene, and the supraclavicular. First of all, let me thank Dr. Sangha and Dr. Hetal, Javed Bhai, and everyone on the dais for giving me this opportunity. So uh, we start with the superficial cervical plexus, which usually originates from the C4, and this usually gives rise to the. Are you able to see this slide?
Yes, sir. Yes,
Yes,
sir.
yes, very well, Sandeep. Very well.
Okay, fine. Thank you so much. So this is the sternocleidomastoid, which is retracted laterally. This is the left side, and you can see the origin of the superficial cervical plexus through a fat pad. This FP is a fat pad, and this originates at usually the midpoint of the sternocleidomastoid. And these are the upper superficial cervical or the cranial nerves. So these are the auricular, occipital, and the facial branches. And if you look at, there is some distance which is between the supraclavicular and the cranial superficial cervical plexus, and this is the caudal superficial cervical plexus, which branches into the lateral most, the intermediate, and the medial. So at times, one of these branches would be absent, and this is more commonly the intermediate or the medial. The lateral branch is usually present every time. And if you like, if you look at it, this is actually in the investing layer of the deep cervical fascia, which we have removed, and you can see some part of it on the top of the brachial plexus. And what you can see here is the phrenic nerve actually. So the investing layer and the scalene fascia, they usually intermingle with each other. And the line which I have drawn is the reason, because if you start injecting more distally, when you get hold of the supraclavicular nerves, selective nerves, the drug should not travel beyond this line, that is beyond the middle scalene muscle in the interscalene, because by diffusion, this is going to cause blockade of the phrenic nerve. And this is the reason why many times when I inject in the investing layer of the deep cervical fascia where these nerves are present caudally, the drug usually is limited just before the interscalene growth in the on the top of the middle scalene muscle. Now, many times we have seen that when you actually when you do the dissections, we see exit of the superficial cervical plexus. And this exit of the superficial cervical plexus is through some tunnels or some facial coverings. And these are very important facial coverings, because when these facial coverings are probed, they can lead to the area of the deep cervical plexus. And this is what exactly is shown here. So what we actually, when we do a superficial cervical plexus and we give a significant volume of local anesthetic, it usually percolates, or it diffuses rather. It channelizes through these particular facial openings. This is actually an exit, but the drug can diffuse through this and then reach the deep cervical plexus. And this is what exactly uh, Pandit JJ has mentioned in long back in British Journal Anesthesia, where they injected actually very large volumes, around 30 to 40 ml in the superficial cervical plexus, which is not required, because nowadays we use hardly around 2 ml when we localize the superficial cervical plexus. And you can again see the distance between these two is around 1 to 2 centimeters. So you can selectively block the supraclavicular nerves. Now, another important aspect that which I have already mentioned in my previous talk, is about the tunnels and grooves which appear in the clavicular region. This is the heat map where more commonly it is present in the mid shaft. And this would be important considering that the supraclavicular nerves would be the major nerves that innervate the clavicle. And moreover, you can see that the intermediate, it goes right up to the level of T4, and it could be important when you use this block for the clavicle surgeries and for the breast surgeries. And there's one more which goes along the shaft of the humerus or the mid arm until the mid of the arm, and this could be important in uh, cases with the proximal humerus. So these two blocks are these two nerves are important: the intermediate and the lateral supraclavicular nerves. And this could probably be also the basis for the clavipectoral fascia block. We are trying to inject at this particular area in the clavipectoral, which engulfs the pectoralis major and the subclavius muscle. This could be another important aspect. So, what would be the sites for supraclavicular or the superficial cervical plexus block? Now, this is the C4. The posterior tubercle is not seen, but the anterior tubercle is seen here. And you can see that the topography that we have described in our article is the superficial cervical plexus would be laterally. The fourth root of phrenic nerve will be medially, and they would be traversing until the investing layer of deep cervical fascia, where they would now diverge from each other. This is the path for the superficial cervical plexus. Some of them would be exiting at this point, where this is the lateral border of the mastoid, while the rest of them would travel, and this would be the exit of the supraclavicular nerves. While the phrenic nerve would travel on the medial aspect of the uh, investing layer of deep cervical fascia. And at the level of C4, this would be the longus colli. There won't be any anterior scalene muscle, which would appear at the level of C5. So potentially, what would be the blocking sites? This would be the one blocking site, which would involve everything. So naturally, you would get the phrenic paresis. Then you have the one which courses through the investing layer of deep cervical fascia, the supraclavicular nerves. This would be another area, and this is would be my choice of the block site, which we commonly request everybody to perform this block at this particular area with hardly 1 or 2 ml of local anesthetic. In case if this is not visible, sometimes you can see that it exits and it lies in the subcutaneous tissue, and then the last would be the subcuticular tissue. So we have got almost 4 sites of injections for just for the supraclavicular block. And later on, you have selective, like you want just the lateral, you can do that. You have the intermediate, you can also block at that particular areas. So that is the path of the supraclavicular nerve. Now, this is a small video, and I have got several of them, which I would like to share as we progress later on during our classes throughout the year. Now, this is a flap which we have, which I have raised in a reverse manner. Normally, we go from the cranial to caudal, but this I raised from caudal to cranial because I wanted to see how far the supraclavicular nerves can traverse. So this entire area, so this the lateral, the intermediate, and the medial, you would be able to see as you can see the supraclavicular nerves. They exit at the lateral border of the sternocleidomastoid, and they traverse in the subcuticular area. These three, 1, 2, and 3. So this could be also the blocking sites just below the skin and the subcute. That also could be one of the blocking sites. So now, if you look at the block in particular, I think This slide should not have been here actually. So this comes. Okay. So here what we have done is we have injected in the in the pre-vertebral fascia, as you can see, and we try to dissect later on. The pre-vertebral fascia is of course the investing layer of deep cervical fascia. That is what we call. Some have different opinion about this, and I respect those opinion. Once you start injecting methylene blue dye just around 3 ml, and when we dissect this, we can see the supraclavicular nerve stained, the phrenic nerve stained, and this is the fourth root of the phrenic nerve, which is being stained here. When we dissect more, we find the C4 and the C5, which have been stained. So probably what we say here is that if you inject around a large volume in the investing layer of deep cervical fascia, it would probably block by proxy the C4 and the C5, which would be the source of origin for the innervation of the clavicle. So if you can just inject around maybe 5 to 6 cc, and if the patient does not have any problem with the phrenic block, then you might use this block as well. So this is what we had hypothesized, and this is what we found. And also the C3 and the C2 were not stained, but the C4 and the C5 were completely stained. So volumes of less than 2 ml would be required to have a phrenic sparing block if you are investing in injecting in the investing layer of deep cervical fascia. Again, the same, the C4 and the C5 forming the phrenic nerve, the supraclavicular nerves originating at this point. You can see that they're all very close to each other in this area. The C2 and the C3 are not stained. That means they are spared. And you can see this topography, which I had explained earlier, the supraclavicular nerve and the fourth phrenic nerve, they all lie together in this particular area. And the slide that I demonstrated where the forceps goes right into the exit or the tunnel of the supraclavicular nerve, it reaches until the deep cervical plexus, which is formed by the C2 and the C3 and the C4. Now coming to the roots, why they are important. So what this researcher they did that they injected inside the C6. This is the posterior tubercle, that's the antitubercle, and you can see that there is an increase in the size of the root, and they injected just around less than 1 ml of black dye. And what they found was that the entire dorsal root ganglion was stained. That means it has gone inside the intervertebral foramen. It spread right into the epidural space. This is the cervical area, and it also spread caudally until the level of cord. So this was found at the level of the infraclavicular area, but at the same time they found very high injection pressure. It means that at no point of the time you should inject inside the fascicle or inside the root. These are all monofasciculars, and it have to be very careful in injections like these. But is a peri-root injection possible? So this is what we did. And what we do here is this is only in the expert's hands or under supervision that you inject at the level of C5, and you can see that this is the C5, and this is the local anesthetic spread. You can see the deformed root right now. This is the longest colli muscle, and you can see the pressure is reduced when you stop injecting, and it increases when you start injecting. So when you stop injecting, the pressure reduces. So this is the root, and this is the posterior and lateral at which point we have injected, and then we come at the level of the cervical plexus and inject a small volume here. Just around 1 ml of local is more than enough for the superficial cervical plexus, and 3 ml around here for the clavicle surgeries. Now, a similar volume when we injected in the cadavers, we found that the entire brachial plexus between the superior trunk and the middle trunk, it was stained. So the 3 ml dye had come right from the level of C5, the C6, the entire the superior trunk, uh, was stained from dorsally, not ventrally. But you could see that the phrenic nerve was totally sprayed in this case. The phrenic nerve was not involved. And here you can see that this is the spinal cord, this is the vertebral body, this is the C5, ventral root C5, this is the vertebral artery here. And you can see when we inject peri-root, it is not intra-root, it is peri-root. You can see that it goes around, there's nothing inside the root, and we inject separately just below the sternocleidomastoid at the cervical plexus. You can see these are also stained. But at the same point, when you start injecting here in this area, you can see some dye also coming close to the level of the root. That means that there is some communication here at this point as well. And this is what we had seen during our dissections, where the superficial leads to deep. Now coming to the interscalene area. So the C5 and the C6, they would form along with the C7. So this would be divided again. So you will have the typical traffic light sign. Now, if you look into the anatomy of the interscalene area, now this is what we have done along with Shiv Prakash in JSS Mysore. Now, this is the lateral border of the interscalene, and this is the medial border of the middle scalene muscle. And you can see that where they meet, this is the apex of the interscalene, and where they diverge, they form the base. It is just at the level of the upper border of the omohyoid. Now, sandwiched between the anterscalene muscle and the middle scalene muscle would appear the brachial plexus. Now, what appears here at this point is we usually call the interscalene brachial plexus, and as we move more caudal, it forms the superior trunk, the C5 and the C6. More important, as you go more proximal, so this could be at the level of maybe C6, this could be C5, and this could be C4. So somewhere at this point, you can see another nerve which originates, traverses entirely on the interscalene muscle, which is engulfed in the with the scalene fascia, which is a part of the investing layer of deep cervical fascia, and hence any local anesthetic injection in the interscalene groove, right from the apex until the base of the interscalene area, at various uh, levels, there would be different incidences of the anatomic phrenic block. Now, anatomic phrenic block is when you inject certain dye and it gets involved, it is results in certain incidences that we call as the anatomic incidence. Now, if it is in a clinical scenario, then we mention it as hemidiaphragmatic paresis in certain incidences. So naturally, as you go more caudal, you will find that the distance increases, and so would be the decreased incidence of the anatomic block of the phrenic nerve. And you can see the supraclavicular nerves which traverse more laterally, but again, they come very close as you move still more cranial. So this, when we dissect the skeletal muscles, when we move them apart, we find that the C5 and the C6 and the C7, and the C8 as well. You can see all these roots which are arising. And now you'll find that the C5 and the two divisions of C6, they will give you the traffic light appearance. You will also see the C7, which is characterized by not possessing the anterior tubercle and in close association with the vertebral artery, which is still medially. So if you dissect in this area and you retract this from the C8, you will find the vertebral artery. So it's quite hidden there. And you can see the C8 is still more caudal and still more medial. So naturally, any injection here is not going to reach the C8, and that would lead to sparing. But look at the distance. The distance is very close and can cause the anatomic phrenic block. And as you go more caudal, somewhere at this point where the C5 and C6 they coalesce together, they form the superior trunk. This is a arbitrary what I have mentioned. This could be different in different personalities. And then here it divides into the medial, which is the nerve to subclavius. This is the one which arises, and it can arise from various like the C6, sometimes from the C5 that we are going to see. You have the anterior division, you have the posterior division as you come more laterally, and the suprascapular nerve. So this is the S, P, and A arrangement, the SPA arrangement of the superior trunk. So nowadays, what we do is that we go still more caudal and we inject in the paraneural tissue of the SPA. So we get hold of the anterior division and the posterior division, which gives you more commonly the anterior division gives you the lateral pectoral nerve, the posterior division gives you the axillary and the radial, and then you have the suprascapular nerve. All these nerves, they would innervate the shoulder joint. Not the radial nerve from the posterior division, but the subscapularis nerve from the posterior division is also going to innervate the shoulder joint. So this is a very important area for the shoulder joint apart from the superior trunk and the interscalene area. Now, this is like what we are looking again, dissecting more further. You can see the nerve to subclavius, which is an important innervation for the clavicle. On the medial aspect, the posterior inferior aspect is the subclavius. And the nerve to subclavius, it reaches the subclavius more posteriorly and inferiorly. If you look at this, you can see how it arises from the probably from the C5. It has got a more emergence from the C5, then coming from the C6 or coming from the trunk. I should have dissected this even more further along this line so that I would have seen that it arises more from the C5. It also means that how C5 is a very important uh, trunk, important route for the clavicle and the shoulder surgeries. Now, this is the area of the superior trunk. This is the suprascapular nerve. And this is the subclavian artery. You can see that which is rests on the first strip. You don't see the T1 because the T1 arises in fact more inferior to the subclavian artery, and then it joins the C8 to form the inferior trunk. And the C7, it doesn't bother about anybody. It just moves along its own and it forms the middle trunk. I did not mention in the last slide was you can see the slips of middle skeleton muscle which we have dissected through which originate the branches of the long thoracic nerve. They all join from C5, C6, and C7 and they form the long thoracic nerve. Sometimes we see the dorsal scapular nerve which arises from C5. I think we have got a separate slide for that as well. These are very important nerves, and you'll realize as we progress through the slides why these nerves are also very important. So we have gone through this, and now we move on to the next. So what are the nerves around the brachial plexus? Now, if you look at this, what we are seeing it from the front, this is the clavicle, this is the subclavius. Now, from top to bottom, as we come, this is the C4, which gives rise to the phrenic nerve along with the C5. You can see that at this point, if you come a bit more caudal, you cannot distinguish between the phrenic nerve, the C5, and the C4. And this is what exactly Kessler has mentioned in his article. Now, as we come more lower down, the C5 and C6 join to form the superior trunk. You can see that this is the dorsal scapular nerve. You can see this is the long thoracic nerve. And you can see also the nerve to subclavius. So multiple nerves which arise in the middle skeletal muscle. These are very important. And this is the spinal accessory nerve, which is still more posterior and lateral. And these are very important when somebody does the block with the neurostimulation, where you have evoked motor responses of the phrenic nerve, long thoracic nerve, dorsal scapular nerve, and spinal accessory nerve. These are the nerves which originate from the brachial plexus but does not have to do anything with the upper limb. Now coming to needle positioning. Now look at this, what I was saying, that when you use ultrasound, you keep your probe on the anterolateral aspect of the neck and you insert your needle through the middle scalene muscle. Now this is likely to impale these nerves. Even the superficial cervical plexus or the supraclavicular nerve, it's likely to impale. It can also injure the dorsal scapular nerve or the long thoracic nerve. So this is the supraclavicular nerve, and this is the long thoracic nerve. So likely to injure these two nerves. Now, where this has to be positioned, whether you have to position on the anterior aspect of the brachial plexus or the posterior aspect of the brachial plexus, that's very important. Now, you are going to, when you start injecting local in clinical cases, you will find that it also lateralizes the entire brachial plexus. Doesn't mean that it's not going on to the anterior scalene. It does go, because we are watching the spread in two-dimensional. So the more the proximal spread, the less the distance, the more caudal you go, more the distance. So the incidence of the phrenic blockade would increase when you go from cranial to caudal. So here it would be like 100%, and here it would be somewhere around at the supraclavicular level. Even with ultrasound, it could be 60% with around 20 ml of local anesthetic agent. And hence, in the past, what we did was we used to use peripheral nerve stimulator at 0.4 milliamperes and start inserting the needle from posteromedial to anterolateral and try to evoke the responses of the back muscles. That is the upper back muscles, that is the rhomboids and levator scapulae. And then we have to negotiate our needle. But now we are able to visualize that, or these nerves. So now it's less commonly, almost like we don't use it any time in our clinical practice. Now, once you start injecting local anesthetic, at this point, it's going to traverse cephalad and caudal. Now, it all depends upon the the speed of injection, the bevel, whether it's cephalad or caudal, and also the compliance of the entire brachial plexus, the tension in the sheath, how much it's going to offer. So all these things matter when you start injecting your local, how much is going more cephalad, cranial, and going to block the phrenic nerve. Now, these are again the same thing what I was mentioning. You can see how they originate from the dorsal aspect of the brachial plexus. Now, we have lifted the entire superior trunk, and you can see the dorsal scapular nerve. You can see the long thoracic C6, the long thoracic C7, and you can also see the supraclavicular nerve, which arises from C4. These are the middle scalene muscles, and these are the slips of middle scalene muscles through which these nerves they traverse. And sometimes you always see anatomical variation of C5, which also has it also traverses through the scalene, over the scalene, or it may be traversing below the scalene muscle. So it's very important to realize some of these anatomic variations when you perform your blocks. But this is not an anatomic variation. This is a normal anatomy where these nerves they arise from its different sources. So, and these are in the path of the in-plane needle trajectory, and that's why some of them they opt for out of plane, where they can avoid the superficial cervical plexus, all these nerves in the middle scalene muscle, and the phrenic nerve. So the out of plane is always gives you a upper edge if you are practicing interscalene block, and it would be the path of choice. But unless you have done a lot of in plane, you you usually don't go in for the out of plane techniques. This is what I was mentioning about how the needle can traverse the middle skeleton muscle and can injure all these nerves which traverse the middle skeleton muscle. So that's the dilemma of the middle skeleton muscle. Now, this article by these authors, they mentioned that the long thoracic nerve is more common from the C5 and the C6, less with a combination of these. But the dorsal scapular nerve is commonest with C5, and we have seen this even in our clinical scenario. And what they mention is that it's better to use ultrasound plus nerve stimulation when you're using an in-plane technique for the interskeleton block. But when if you happen to visualize these nerves, then it may not be necessary to always have these nerve stimulation in your practice. This is an important article by Kessler where they analyzed the effect of caudal descent, that is, with the required as a reference. Caudal descent is you start shifting the probe from the level of C4 until the level of C7, and then you see what they found was that for each 1 centimeter caudal descent, the phrenic nerve would diverge 3 millimeters from the brachial plexus. And what they implied was that more caudal approaches may reduce but do not eliminate phrenic nerve block. But I'm really not sure that how important is still the phrenic sparing blocks, particularly in ASA 1 and 2, and those who do not have any history of chronic obstructive airway disease. I would still opt for an interskeleton block. And as I mentioned earlier, you can see at the level of C5 and C6, as we had seen in earlier slides, the separation of phrenic nerve is indistinguishable. So for students, this particular thing is very important. 1 centimeter caudal descent and the phrenic nerve diverges every 3 millimeters. Now we have seen that there is a facial continuity. We will see that the spread can be unpredictable, and this is neck has got a very small safety margins, particularly in interskeleton block. So if you look at this picture, this is a different cadaver, and what we found here was that you can see they almost are in the same sheath. So single sheath which engulfs the brachial plexus and the phrenic nerve. So this is the superior trunk which is very close to the phrenic nerve, and you can see the phrenic nerve course over the anterior scalene muscle, and this is the superior trunk. So any injections at this point of in this particular area is naturally going to cause the phrenic blockade, but as you go more distal, it is less likely. This is a needle which is inserted more cranial, and this is a needle which is inserted more caudal, where the C5 and C6 they coalesce, and this forms the superior trunk. This is more at the level of the C5 and C6, which are separate. This could be the interscalene, while this could be the superior trunk. So this is one anatomical variation that we found. I think this was in the crab, which was in organized in Bangalore, and the anatomy team there they found that this is the C5 and C6 forming the superior trunk, and this gives the supra scapular nerve, the posterior division, and the anterior division. That's the middle. So C7, this is the C8 and T1 forming the inferior trunk, and this is the subclavian artery over the first rib. What you can see is the C5. Look at this. The C5, the nerve to subclavius, is going right into the lateral end of the clavicle. So this we are really not sure about this anatomic variation because the subclavius muscle is posterior and inferior. Why this nerve should go more lateral? What exactly is this nerve? So we had a lot of discussions, but we really could not come across any anatomical variation in this form. Where the C5, well, there was a direct branch uh, which innervated the lateral end of the clavicle. So we were really not sure what this nerve is. So these some anatomic variations. For example, you do a scud block. Where do you do the scud block? You do the scud block at this point. where the C5 and C6 coalesce. So if this is going to innervate the lateral end of the clavicle, you are going to miss this nerve, and that's going to cause an inadequate block. And you may not be sure of why your block failed. So that was probably the nerve of subclavius, very anomalous course and a very different course. And we are really not sure whether this was nerve to subclavius. Now, coming to fascicular distribution, we are going into a bit detail about this. For this, you have to understand histology of the brachial plexus. Now, these are the sections of the brachial plexus. What you are seeing here is C5. What you are seeing here is C6. And this is the C7. I'm really not sure whether this has been labeled appropriately as C6 and then C7 because this originated before Carlo Franco mentioned the traffic light sign. But what important here is that these is the interscalene groove, and this interscalene groove is sandwiched between the interscalene muscle medially and the medial scalene muscle laterally. And you can see that this is all what is neural tissue and which is surrounded by non-neural tissue and which is also engulfed in one particular sheath. So probably this is the epineurum of the this particular root, that is the C6, and this would be uh, the perineurium, and then this probably could be the endoneurium. That is what it could be. And in between these two roots is another structure which does not have any architecture like this. So this is a non-neural tissue. Again, in between these two, this is a non-neural tissue. And again here, this is a non-neural tissue. So it means that this non-neural tissue is made of what we call as the connective tissue with adipocytes. And this adipose tissue is very, very important. And a lot of stress has been made on the adipose tissue, which lies inside the nerve as well, inside this root as well. So these could be again the adipose tissue inside the nerve. So this could be the intraneural adipose tissue. This is the extraneural adipose tissue. And similar exists for the supraclavicular area. So in the supraclavicular area, the subclavian artery, this could be one particular sheath which engulfs the brachial plexus. That could be the second, and this could be the third. So this could be the beginning of the superior trunk. This could be the divisions of the middle trunk, and this could probably be the inferior trunk. So this is how we are looking at. And you can also see that now here you see there is less of those areas that you can see more of gray areas and less of white areas. But there are a lot of white areas which are outside these gray areas. So this is all adipose tissue, and there is less of adipose tissue here inside the supraclavicular. But you can see again there is a lot of adipose tissue here at the level of the inferior trunk. So this can change. It may not be the same everywhere. Sometimes you can have in the superior and the middle. Sometimes you may not have in the inferior. So this the adipose site or the adipose tissue content can change. And the presence of this adipose tissue inside this particular root is important because it will prevent or it provides a cushioning effect for the advancing needle tip. And this is where the importance lies. Coming to some of the cross sections of the interscalene. Now you can see that this is what we did in grass. Now you can see this is the investing layer of deep cervical fascia with a scalene fascia on the top of this. And you can see that this is the entire one root, that is the C6, the C7 and C8. Now the dark browns are the fascicles, the light brown, as I said, non-neural tissue, and here you can see the adipose tissue going all around. And this is the middle scalene muscle.
આગળ question sir, intramural injection માટે અમને આટલા દિવસ જગ્યા રખીએ કે
Can you ask them to stop?
Yes, sir,
You
done.
should make them mute actually. So this is the epimysium of this particular area. that is the middle scalene muscle, and this is the epineurium of the C5. That's the epineurium. You can clearly see it going around the C6. You can see it going around the C7. So between the epineurium of the root and the epimysium, this area is the one which is called as the periplexus. And here you can see that there is a safe zone. So this area you can easily insert the needle here at this point and inject local anesthetic at this point or at this point without penetrating the fascicle. So this epineurium is very important because if you happen to uh, inject inside this area, then it becomes what we call as the subepineurial injections. So as I said that this becomes the periplexus. So the second area would be the intraplexus, which is in between these two. And it could be also inside the epineurium. That also could be the intraplexus. So inside the epineurium somewhere here, that could also be the intraplexus. So this is a very safe zone, which you should be always looking for when you inject your local anesthetic in the interscalene area. It gives you the cushioning effect, the adipose tissue. So again, as I said that this black arrows, they show the epineurial tissue. Some of the slides might be repeated because I want to have you a clear-cut view of what is the epimysium, what is the epineurium, and what is the safe zone between these two. And usually you get such kind of safe zone like this fat tissue here. You can see that this could be a very safe zone. And why this is safe zone? Because of two reasons. It will help in a cushioning effect to the advancing needle tip and reduce the nerve injuries or neural injuries. And second thing, it will cause a safe passage of local anesthetic because this is the least resistance pathway. So this is going to give you a spread as you start injecting local. You can see the spread going all across the adipose tissue. So that would be the periplexus block. And this would be the intraplexus. As you start advancing your needle, sometimes you penetrate this, go beyond this, then you withdraw this needle tip and start injecting here, separating these two. Now, this is very close to the epineurium, and sometimes they are stuck together without any clear-cut distinction between these two. So that's going to cause some sort of neural injuries which go undiagnosed. Patient complaining of chronic pain in certain areas, which you would feel that could be result of the surgical procedure. That probably could be the needle tip injuring the fascicles. So there would be only one or two fascicles which would be injured, not the whole of the root. And when you start injecting local in the intraplexus, you will find that the drug is going to diffuse more medially, going on to the anterior aspect or the superior aspect of the anteroscalene muscle, and again will lead to the phrenic paresis. Not only that, I experimented some intraplexus and I took some contrast studies which have not been included in this talk. But I found that when you inject at a level of C7, there is more chance of the drug going inside the epidural space. And we saw that with just around 5 ml of local at the level of C7, the drug trickled into the epidural space. Now here with this needle at the C7, if you start injecting, there is no anterior tubercle, so there will be more injection of the local going into the medial side and going into the prevertebral area or the paravertebral area. So you have to be very cautious when you start injecting at the level of C7. Intraplexus is no, and every time it's always the periplexus in this particular area. So it's the same slide again, just reinforcing. This is the epineurium. This is the epineurium. This is the epimysium. So in between the two, more into the safe zone, which is a more larger zone. So try to look out in the interscalene area for these larger zones where you can injure your local anesthetic very safely. This is all non-neural connective tissue. So that's the adipose tissue. And this is the epineurium, which surrounds the entire root. This is one fascicle. which this would be the perineurium, which is more of a histological diagnosis. Now, what happened when they injected just around less than 0.5 ml of the black dye? It's called as the Indian ink. When they started injecting, what they found was that it when they injected periplexus, they found that it was very close between the two fascicles. When they injected the intraplexus, it was between the fascicles. While they injected the periplexus, it was quite away from the fascicles, and there was also some intramuscular ink, but none of the this thing were injured here. Neither it was injured here, but they don't advise injecting in this particular fashion. Now, this is a video of the intraplexus where the needle is seen here. You can see that there is some hyperechoic structure there where I'm trying to insert my needle. I inject local and I can see that it is separation of these two, and with the drug going more medially as well, and then lateralizing here at this point. So this is the intraplexus, which is not recommended. This is not recommended. So what you need to do is you need to give a periplexus block. Again, it's the same. When they gave intraplexus, they found that more of the drug had gone subepineurial. Now, this is the epineurium, and the black is inside the epineurium, so it's called as a subepineurium. So the subepineurial injections are always equivalent to neural injuries. So any subepineurial injection is peripheral nerve injury. Now, peripheral nerve injury or the subepineurial injections can be intravascular or it can be extravascular. So most of the times it's extravascular, but do not take a chance to inject inside or within the epineurium. I think this was done today. Yeah, it was done today. So you can see now, injecting here, you can see a couple of facial sheaths getting separated. I am far away from the brachial plexus. I start injecting local anesthetic. A small pop I get here. And when I inject a small volume, you can see the spread here. You can see the couple of sheaths being raised. This is one sheath which is floating here. That's the second sheath. And as I come more, I withdraw the needle and then I will be going towards the C5. So I'm now positioning here and you can see that there will be a small pop, a subtle pop. Yes, and then I inject. You can see the sheath being raised from the C5. See the sheath being raised from the C5 as well, and it gets going onto the superior aspect of the C5. So this is compartmentalized. Now, whether to call it intraplexus, because I've raised the sheath away from the epineurium of the root. Now, whether this area is intraplexus and this is periplexus, that has to be defined. So that detailing has to be done when you do perform each of these blocks. Now, coming to the level of the superior trunk, distal to the interscalene area. Now, we know that this is the omohyoid. This is the right side of the brachial plexus. So the supraclavicular nerve has been divided with the posterior division and the anterior division, and the needle is inserted between the suprascapular nerve and the posterior division in the paraneural sheath, or you can also inject between the posterior and the anterior division because it gives you a very safe area, unlike the superior trunk. But the superior trunk is one complete C5 and C6. Here you have got some paraneural tissues where this can act as safe zone for injections of local anesthetics. Again, as I mentioned, suprascapular nerve, posterior and anterior divisions all would be required for the shoulder joint. Now, when you do that, these blocks, You can see the suprascapular nerve, the posterior and the anterior division. This is a catheter which has been placed actually, and you can start injecting local. I'm not happy with the spread because it's more medial. So I withdrew the catheter and I start injecting, and you can see now the superior trunk, it gets floated when I start injecting to the catheter. So this sometimes we use catheters, not every time. And this local anesthetic is now uh, at least 3/4 of the has been soaked with the local anesthetic spread. So that's the catheter. You can see this is the catheter here. Now I have withdrawn the catheter and then I start injecting local. You can see the spread beneath the superior trunk as it lifts the entire uh, posterior anterior divisions and the suprascapular nerve as well. Now, what these authors they found was when they injected at the level of the superior trunk, the suprascapular nerve. Sorry, this is a separate study, the subomoid suprascapular nerve. Anyways, we are going to also look into this. They found that it ascends until the level of C5 without any staining of the phrenic nerve. Now, what is the suprascapular nerve? We did the superior trunk block at this point, but we are going more distal, and we are going caudal and going lateral, and you can see the needle position at the suprascapular nerve. So now when you start injecting, this drug is going to ascend more cranial, but some of it is going to get spilled on the anterior and the posterior divisions because they are still in the same sheath. So as it goes more lateral, then it gets disconnected from the entire brachial plexus. So to some extent, the sheath of the brachial plexus, it follows and then it moves away from the brachial plexus sheath, and then it has got its independent sheath, the scapular nerve. So when these authors they did study, they found that you require 4.2 ml of the injected to spare the phrenic nerve. So now in future, if you want to do any studies, you have to use the volume less than 4 ml. Only then your study would be valid because this has given you a benchmark. And what they found out was that when you inject in the suprascapular nerve, some it goes right up to the level of the phrenic nerve which gets stained, while some it spares the phrenic nerve totally. It doesn't cause the phrenic paresis or anatomic phrenic block. So we looked into the path of the staining of the phrenic nerve after injecting in the suprascapular nerve because we were quite surprised that why so distal injection should cause a anatomic phrenic block. So we did two things. One was we wanted to understand the mechanism, and we understood that if you inject at the suprascapular, even in this area, you can see that's a very dense staining with 5 ml. The spread was to the posterior and anterior division. It also led to cephalad and more medial, and even the nerve to subclavius was also stained. So probably, in fact, if you inject at this point, you can also get hold of the shoulder joint and the clavicle as well. And the next we wanted to look why the phrenic nerve was stained in certain specimens. It was not stained here, but in certain specimens it was stained. So what we found was that when you inject here at the most distal site, the dye goes dorsal to the brachial plexus, it winds around the C5, and then it descends onto the phrenic. Now there is a article in 1960 by Kodoma who mentions that there is a phrenico-scapular connection because they both come from C5. Some of the fascicles are interrelated with the fascicles of the phrenic nerve, and this is the reason why you find the dye which you inject distally coming more cranial. Coming to the supraclavicular area, it's almost 8. Should we stop or we finish the supraclavicular?
Sir, we finished the supraclavicular.
Yeah. So the supraclavicular, you can see that I call it as a step 12 appearance. As you start dissecting, you will find the C5 and C6, the C7, C8, and the T1. And you get a lot of these nerves. As you have seen these nerves, that the spar, the nerve to subclavius. And you need to go still below this to get hold of the divisions of C7, the C8, and the T1, which are more important. So naturally, when you inject at the level of C5 and C6, you don't get any uh, anesthetic effect at the level of C8 and T1. But when you inject at the level of C7, you might get hold of C8 and T1. And if you get hold of C8 and T1 with injections here, this will be spared. So that is how it is. Importantly, this is the dorsal scapular artery, which traverses through some of the roots that we are going to look into. This is the front view, C5, C6 forming superior trunk, giving off the branches, C7 as the middle trunk, the C8, the subclavian artery over the and the T1, which is a small branch. It will join the C8 to form the inferior trunk. The thyrocervical trunk giving the inferior thyroid artery, the transverse cervical artery which traverses over the brachial plexus, and more importantly, the dorsal scapular artery, which is 34 to 33% between the C7 and between the C6 and the C7 and C7 and C8. And the suprascapular artery is more commonly found, but it's not visualized in most of the imaging techniques. Now, these are important because they also form the hypoechoic shadows, and unless you have a color on, you may not able to recognize this. This we are going to see in the next slide. Now, here during a dissection, when the surgeon was dissecting, I, uh, I said that this is the artery, that's the dorsal scapular artery, which I had seen earlier. You can see that it is pulsating. This was a brachial plexus surgery, which was being performed. And in the same patient, I had seen it earlier. So this is the dorsal scapular artery, which is traversing the brachial plexus, which divides the brachial plexus actually into the superior and the inferior areas. So sometimes you can also assist the surgeon by during the brachial plexus surgeries. Now this article, it mentions that with probe position of B and C, so this is at the brachial plexus on the pleura and the brachial plexus between the scalene muscles. You will find the transverse cervical artery and dorsal scapular artery. So this is quite true. You will always find this, and not with the position A. So with the position A, which is on the rib, you may not be able to find this. But we have also seen in this area as well, and many of you must have seen the brachial plexus being divided into superior and inferior, which was not found in this study. Coming to the cross section of the supraclavicular. Now, this is a very important slide. Now, this is the lung. These are the ribs. Now, this is the first rib. This is the subclavian artery, as you can see. And what you can see here is the entire brachial plexus, which is superior and lateral. So this is the medial aspect. This is the superior and lateral. The entire brachial plexus is engulfed in one particular sheath. Can you see this sheath going around? That's one particular sheath. And inside you'll find several more sheaths which are given up from this sheath, and this all gets compartmentalized. Now, what is important for us is the corner pocket. Everybody says corner pocket. So this is the angle between the subclavian artery and the first rib, which may or may not host the inferior trunk. Sometimes you will find entire thing on the top of the brachial plexus. Even if you go still more quarter, you will still find the inferior the corner pocket, which could be empty at times. So this is the T1, this is the C8, this is the C7, that's the C5 and C6. So that is how the brachial plexus divisions are positioned at the level of the first strip. So the first strip, the subclavian artery, on the top of it, the brachial plexus superior and lateral to it. So this is the position of your probe. You need to see all these structures when you do a brachial plexus block. Now again, the same thing, the fascicles and the non-neural tissues. So we don't have to discuss much about this. This is the fascicle, that's the non-fascicular. So this is all the adipose tissue. So what you need to do is you have to get hold of these connective tissues or the adipose tissues and just keep on injecting local in these areas to get hold of the fascicles to block all these fascicles. Now, if you look at this, there are a couple of needle positions. For example, the intracluster. What the intracluster means? This is the entire brachial plexus sheath. You can see that the needle is right going into this hyperechoic area. So that's the non-connective tissue or the non-neural tissue. And this is where the needle would be. And when you start injecting local, that would be the spread of the local. But what about the other areas? So then it came as multiple intracluster injections. So the initial was a single. So when the flow was limited, they started doing multiple intracluster injections. So at various points, they started giving local. But then what about the corner pocket? So the corner pocket was not being like the other sparing or the C8 and T1 sparing. So that was the problem with the intracluster injections. Plus, there could be a potential intraneural or the subepidural spread, and this required expert needle visualization when you do the intracluster blocks. And these intracluster blocks, when they studied with histological sections, they found that it led to more of subepidural injections and even fascicular damage. So the intracluster block was then condemned, and they said that this cannot be recommended because they found subperineural injections in 24%, and in 9 of the 10 specimens, the ink was intrafascicular, leading to neural damage. So the intracluster injection is not recommended henceforth. So they came with corner pocket injections. So we understood corner pocket, the angle between the artery and the first strip. You inject local anesthetic here. But you found that there was no local spread in the middle and the superior trunk, and these were spared. And most of these we have seen even with experimental contrast studies that I did in my institute. We found that it goes more infraclavicular as well. So if you insert a needle at the corner pocket between the subclavian artery and the first strip, definitely you will get hold of this particular area, that is the inferior trunk. And but you would not get the middle trunk. Probably there would be some diffusion here, but definitely not the superior trunk. So that was a big problem again. So they came out with the more recent one, that is the intertruncals, and I think Professor Shiva and his colleagues, they have mentioned about this in one of the articles, the intertruncal block as well. They gave very small volumes in between the superior trunk and the middle and the inferior. And where do they give these injections? They are injecting in the connective tissue or the adipose tissue between these two planes. So it is just like an interfacial plane block, but between the two divisions, the superior and the middle and the inferior. So what happens is you get the entire spectrum where you get hold of all the divisions of the brachial plexus with very minimum volume of local anesthetic agent. So that's the intertruncal. So this is the plane. So this is the superior trunk, the suprascapular anterior and posterior divisions, and this is the middle trunk. You can find the plane here. Then you can find another plane here, and you give another injection of local anesthetic here. And you really don't go to the corner pocket. But probably there is also sparing of this ulnar nerve in this particular area. So this is the histology where you can see the facial planes, and you can also see the adipose tissue which they have colored. But remember that this is a histological slide. It is not an ultrasound image. There's a lot of difference between the ultrasound image and the histological slide, where you cannot see an adipose tissue in the ultrasound image so perfectly fine, which you can see in the histological slide. So what they do is, what I recommend is drop your injection in the adipose tissue between the brachial trunks. That's all what you have to do between these two areas. If you can get hold of these two areas and inject local anesthetic, just at the corner, you need not go right inside, because this adipose tissue is giving you the least resistance path through which the local anesthetic can spread all around. And this is a modern way of giving the block, target the adipose tissue. So Adipose tissue and local anesthetic flow, it does not have a barrier. It facilitates dispersion. It offers a low resistance channel or pathway. So actually the intertruncal approach, you need to target the adipose tissue between the two areas, as I mentioned earlier. And from then onwards, the local anesthetic, it diffuses through the epineurium along a concentration gradient and would lead to an adequate block. There are, of course, some hybrid techniques like which have been like a combination of the intracluster with corner pocket, intertruncal with corner pocket, the upper and lower truncal, the periplexus and corner pocket, and the intracluster with intratruncals. And these are the injection planes. And these are some of the advantages, which, of course, is always open to discussion. And there can be a lot of debate and controversies regarding each of these techniques. So corner pocket injection plus intracluster is something like this. This is the intracluster and corner pocket and intertruncals. So these are all the intertruncals along with the corner pocket. So this is something which has been described in the literature, which they say that most of the times they give you an adequate block, but I'm not sure about the superior trunk again. We described sometimes back the middle trunk, not sometimes recently. And what is the middle trunk block? So the superior trunk, the middle trunk, and the inferior trunk. We were to just pierce this and inject. So this was a cadaveric study that we did, and we found that the entire spread with 15 ml of volume, we found that the C5 until everything was heavily stained when you use 15 ml. So if you use 15 ml, you can see the specimen which we retrieved very densely stained. With 7.5 ml, you could see the staining of just the C6, C7, the C8, and T1. With 3.5 ml, there was hardly any stain, but somehow the ferric was stained. I'm not sure why this could be stained. So what we recommended was that if you can just inject around 15 ml at the middle trunk. So the middle trunk is just pierce this. You need not go deep and inject at this point. So with 15 ml, you can probably get an anesthetic block. And with 7.5 ml, you can get an analgesic block. So we are now have done a clinical study, and we will be soon uploading that as well. So coming to a conclusion, the interscalene block and the supraclavicular block, it depends a lot on the adipose site rich facial planes. There is no need of a direct nerve contact. It means that you have that the needle tip has to be in the facial planes where you have got adipocytes, which would be the future for the local anesthetic diffusion. This is some of the table which I have made considering the entire talk. So low neural and high neural, and you need to read some of the articles, particularly by Moyeri and in Anesthesiology Journal, where they have come out with a quantitative architecture of the brachial plexus, where they have mentioned about the ratio of the neural and the non-neural tissue, how it keeps on changing when we go from the cranial to caudal. And everything depends upon the adipose tissue. So it's called like adipocyte guided local anesthetic spread. So this is what has been recommended nowadays. So the infraclavicular and axillary, maybe the next session. Thank you very much.
That's a wonderful presentation, sir. It is eye-opening as well as learn lots of new things. I will open the session for questions and answer.
Yeah, Hetal, this is at a bit different level. I did not want to take a normal
Yes, sir.
anatomy of the brachial plexus. I wanted to show something which we have done in the past and in the present, and how the future would be for all the fellows and also ourselves. We can also learn a lot from out of it, isn't
Yes,
it?
true, sir. Sir, it shows your hard work of, I will say, 25 or 30 years.
Yeah. Yeah.
So, Javed, sir.
Hello.
Yes, sir.
Yeah, yeah. If Dr. Sandeep Diwan is presenting something, it will be out of box thinking as well as the performance. So it's mesmerizing, eye-opening for so many of us. Excellent presentation, Sandeep bhai. It was expected from you.
Yeah, but Hetal bhai and Javed, I need a lot of questions because only then I can work on it and we can have something. I think something says something in chat.
Yeah, there is a question from Dr. Rajaram Prabhu that is there any delay in onset of block by the middle trunk single injection technique, sir?
Yeah, that's a very nice question actually, and we have seen that. We have used it in as an analgesic procedure. We have not used in anesthetic procedure. So we combine it with general anesthesia, and usually it takes around 30 minutes for the entire thing to get ready. So by the time the surgeon arrives and he takes a knife on the skin, it's usually the block has taken up. So we really have not seen into the anesthetic. We would love to see the anesthetic effect, whether there would be a delay of how many minutes or it would be a faster onset. I think that question is very, very valid.
Yeah. Sir, I wanted to ask you a question. In the era of landmark guided blocks, maybe before 20-25 years, for supraclavicular, we were used to just hit the first rib and injecting the drug. Same way, for
Yes.
interscalene, we were used to hit the Czech neck tubercle, I mean C6, and were used to inject the drug. Was it volume dependent only, or we were in particular areas, sir?
Again, Hetal, the same thing. For example, now if I this slide is seen, no?
Yes, sir.
Yes,
Yeah,
yes.
yeah. So now see, when you said that during the landmark techniques, what we used to do, we used to come maybe through the brachial plexus. We did not get any paresthesia. We would be going until maybe hitting the first tip without paresthesia. We
Yes,
give
sir.
some volume of local anesthetic, palpating the artery. So probably we were in the corner pocket.
Yes, sir.
So we gave around maybe 10 ml of local anesthetic. Then I used to withdraw the needle a bit and inject, so probably the middle trunk, and then again inject probably the superior trunk. So we used to give 10 ml, 10 and 10. So 30 ml of local anesthetic would naturally soak the entire thing,
Yeah.
isn't it?
Sir, we were taught to inject at three location on the rib only in faint
Yes.
separation.
So on the rib itself.
Yeah.
So now if you look at the cross sections, the rib hardly there is any brachial plexus elements. Most of these elements you will find superior and lateral to the subclavian artery,
True, sir.
and it is off the first rib.
Hmm.
So I'm not sure whether there was really any point injecting local anesthetic the entire 30 ml or at different planes. So were you going from the anterior aspect of the rib to the posterior aspect of the rib? How was it?
Sir,
Or
from
from the
medial to
middle to the lateral?
medial to the lateral.
From the medial to lateral.
Yeah.
So from the middle to lateral, again, it's most of the times it's inferior trunk. I'm not sure whether the middle trunk would be still at this point or it would be away from the,
But
I mean,
fortunately for us, it was working.
yeah, correct. So it
Sandeep
means
bhai,
that it was more of a volume dependent rather
Yes.
than, yes, correct.
Yes, that's what I was thinking. Because we were used to inject 30-35 ml of LA.
Yes, yes, yeah. The maximum that has been injected is 52 ml by William Orme in one of his studies.
Javed bhai, you were telling.
Sandeep bhai,
Yes.
you used to talk about interscreen block about the circumference of the neck, 40 centimeter less or more. So
Yes.
you didn't mention that. Can you please elaborate that point?
No, no. See, we are currently studying a cohort of, I think the sample size is around 500 patients where we are trying to observe the hemodiaphragmatic paresis irrespective of the volume, concentration, performer, and the site of injection.
Hmm.
We found that the neck circumference, if it is more than 40,
Hmm.
usually the patient has hemodiaphragmatic paresis, but really does not have any problem that the patient should be shifted to PACU or HDU or in ICU. These are all ASA1 and probably ASA2 patients at the most, not ASA3 and 4, and not, of course, having any chronic obstructive airway disease. So any patients with short neck and neck circumference of more than 40. So this we have done an interim analysis, and then this has come. We have come into a conclusion. The rest of the study is yet to be done. But please take care if there is a larger neck circumference. I think it's very prudent to go still more caudal than at the interscalene area. So superior trunk would be more better than the interscalene jaw.
Okay. That's got it point.
Yeah.
Harshal,
Harshal has
Harshal.
one question. Harshal?
Yes, Sandeep sir, fantastic as usual. So I just wanted to understand the relationship between that the variations of the brachial plexus as you shown, and what you said. So many a times while doing these interscalene blocks, which you also have mentioned in the cadaveric studies about the variations, the C5 tends to, as it comes out of the transverse the exit, it winds around that scalene muscle, and by the time it comes back into position, it is almost at the supraclavicular level. So sometimes it becomes a little difficult to give that low volume blocks at the C5 C6, because by the time the C6 comes in the interscalene groove, the C5 is gone, almost like like a phrenic nerve winds around that scalene muscle and then comes back into uh, the supraclavicular areas, which you also mentioned as the variation sometimes that C5 either goes above, into, or below those the scalene muscles. But that variation seems to be more than just a one-off, because I seem to have seen it quite a few times in the last few scans that we have done, is that C5 is just going around the scalene muscle. Is that something that you have also seen, or anybody else has seen? Because then giving the low volume blocks at that C5 C6 becomes a little challenging, because that C5 is just not there in the picture at that time. It's just far away from it. So any sort of, when you do those dissections, is that something that is common in variations, or?
No, yeah, the dissection sometimes it does reveal this, what you exactly said, Harshal. The winding of the C5 around, and we saw it today as well. I'm just trying to see whether I will be able to share this with you, because this is also very important, as you have rightly said this. Absolutely rightly, you have said this. So, not this one. Just give me a minute. So, continuing with the discussion until I get that. What you have been saying, or you have been watching, is the C5 going around the around the interscalene muscle, right?
Yes, I mean, but it's so if you start tracing it, so the C5 comes out, then the C6 comes out, and the C7. So you're trying to get your, those the nerve roots or the ventral rami in between the scalenite to give you a good picture. But many a times, what happens, by the time the C6 comes out, the C5 is already gone, around that the scalene muscle, and it's not really in the area that you would inject. So I don't know whether you need to do a separate C5 somewhere, but then that becomes a little challenging, especially if you're telling fellows and all to do it, even for someone who does it regularly.
Yes, yes. No, this is exactly the reason why the previous neurostimulation blocks, they used to fail. When you palpate the interscalene groove, and probably the C5 is right on the interscalene muscle, and you insert your needle through the interscalene, which is like an out of plane technique for a neurostimulation. Your
Right.
needle lands directly on C6, and you will get a C6 stimulation, where even you can get a biceps and the deltoid, because of fascicles are same from C5 and C6. And then you inject local anesthetic, you anticipate that it is all blocked, and the patient has pain when the surgeon starts manipulating the bone. So you have missed the C5 in that case. And as you rightly said, if you go more caudal, you come at the level of the supraclavicular. It is at that point that you start getting the contractions. I mean, the C5 involvement.
Yes. So, I mean, that's more common than. I mean, maybe I just had those one or two patients which came at that point of time, but I
Right,
thought
right,
maybe
right.
it's more.
No, no, this is a common variation. C5 is a common variation. In fact, Anil Sardesai from England, he has mentioned this in one of his articles, where the C5 variation, it might go through the anteroscalene, above the anteroscalene, and this is a quite common phenomenon. So what I ask my colleagues and I do myself is, you have to scan the entire brachial plexus and rule out or exclude that the C5, you're not missing the C5. And then only, as you rightly said, you can come more caudal, where it's the C5 joins the main interscalene and then inject, or you can inject separately the C5 when it's on the interscalene muscle. But there is a possibility of phrenic block again if you inject on the top of the interscalene muscle. So the best possibility is to get it more caudal in the interscalene groove, and then you inject local anesthetic.
Right. Great. Thank you.
Sir, next question is, what is optimum volume for interscalene block?
So if you're giving by neurostimulation, like what we used to do in the past, 20 to 25 ml would be, but nowadays what we do is we do a real dynamic scan. And we try to observe that the spread of local anesthetic is not going more cranial beyond the level of C5, and its spread is adequate, which is posterior and medial. Isn't it? That should
Yes.
be the answer. Yeah. If you have
Yes.
any different opinion, you can mention, Hetal.
No, I agree with you, sir. So I believe for interscalene, you can block easily. You can achieve surgical anesthesia with 10 to 12 ml of LA, I believe.
Uh-huh.
Is that right, sir?
So around 10 to 12 ml is more than enough for a surgical procedure. And
Yeah.
in a very frail patient, I have used just 4 ml, like the last time I had mentioned in the other talk.
Yes, sir. Yes, sir.
Very
Agree.
frail, very frail,
Yeah.
yes.
Another question is, during intertruncal approach from practical point of view during day-to-day practice, how safely can it be done, as fear of injuring now will be present in back of the mind in terms of needle approach, volume, etc. Mm,
This is one thing that has also been, it's affecting me as well. Like needling in two positions in the intertruncal approach. But as you start getting used to it, like we demonstrated in the volunteers, as well as not in the volunteers, in the workshops, live workshops, as a cadaveric workshops, there a subtle pop is always felt, and this is very important as you traverse the sheath of the brachial plexus and you start injecting a very test dose, a very small volume, and try to see that it dissects the plane between the brachial plexus and the epimysium of the muscle, middle scalene muscle. And then you start progressing very slowly, and you can see that there are several sheaths which form many compartments in the brachial plexus. So they start lifting up with very slow injections. So that is how we approach for this. The other best way is to go for the corner pocket, and then you can go for the intertruncal for having a complete block. But I still agree with that there could be a possibility of nerve injury as well.
Next is request from Dr. Divya to show the video of suprascapular nerve block, position of the needle and identification of the nerve. If you have, sir.
Actually, I don't have it right now.
Okay,
But yeah, so sometimes maybe in the next talk, the cadaveric talk, I will include that this video
thank you,
to
sir.
start to begin with. Yes, yes, I can include that.
I think Anshuman had some question, but he has deleted the question. Anshuman, you want to ask? Anshuman, are you there?
Yes, sir.
Yeah.
Good evening, sir. Anshuman here, sir.
Yeah, tell me, Anshuman, how are you?
Absolutely fine, sir. Sir, actually, I had, so what do you suggest, sir? What is better option, going for an interfascicular injection or a safe zone injection?
So interfascicular, we don't go at all. We usually go for the safe zone, as we demonstrated in that particular interscalene block. I nowadays in the past when I had bought that ultrasound machine in 2006 until maybe 2010, I had used that this thing interfascicular. But nowadays, no, it's a big no. And most of us, like in our institute, all of us, we practice the periplexus block rather than the intraplexus block. I think it's more safe, no?
And
Yeah,
sir,
I
does
have
it
a
make any
query if
difference
I
in the
can.
does it make any difference in the onset of block, sir, where you
No,
are
no, no.
blocking?
No, no, no. So, yeah, so there's one thing that I would also like to add here, Anshuman. Uh, Recently, doing my blocks, I sometimes use interfascicular, a very small volume, and I combine it with the extrafascicular. So it is like intraplexus plus extraplexus, a very small volume of intraplexus. If you have a safe zone, like in between the two, only then I try to penetrate that area, and then I combine with the periplexus. So just trying to see whether this is going to give a better or a rapid onset of action. I'm really not sure why a very rapid onset of action is required when the surgeons can wait for a couple of minutes. So I'm really
Agreed,
not sure about
agreed, sir. Absolutely agreed, sir. Sir, actually, the biggest drawback of the proponents for of all these intervesicular blocks is that the time is you decrease the time of onset.
it.
But I don't know if it is maybe safety should be paramount. I think that's my take, sir.
I
That's
think you
all.
should be more in our institute. We try to be more safe rather than try to be more invasive. So that should be the dictum in all our regional anesthesia practice. Try to be more safe than being more invasive.
yeah.
Agreed, sir. Agreed. Thank you, sir.
We too give extra plexus only. We hardly now
Yeah,
go intraplexus.
right.
I have a query. Can I just raise a question? Good evening, Dr. Diwan, Dr. Anupama here. You always amaze with your presentations. Now, we're doing a study at our institute with the subcortical brachialis block with scud block for shoulder surgeries. Now, often I have patients who complain of when the surgeon takes a posterior incision on the shoulder, that area gets spared. What do we do for that?
Yeah. Do you combine it with superficial cervical plexus or no?
No, I don't. That's right. I've not combined with the superficial cervical. It's either scud
So
block only, or probably it's, of course, under GA and a subcortical brachialis block for the shoulder surgeries. As a study, we are doing it. So I used to give the suprascapular at the scapular level, at the how the landmark based technique we used to do with the ultrasound. Yet we find that if the surgeon takes an incision on the posterior aspect of the shoulder, that's where the patient complains of pain post-op.
Okay. Um, so in the scud block, actually, it means that you have been including the supraclavicular block as well. The supraclavicular block has got a wide area of innervation. The last time I had spoken about this, where I had also shown a picture where it involves the posterior aspect of the shoulder blade as well. So the C4 has got a very large innervation from the posterior until the anterior and the lateral aspect as well. So if you give this supraclavicular nerve block a bit more at the level of the investing layer of deep cervical, where you've got all the three nerves, somewhere at that point, if you inject your local, I think that should take care of the posterior aspect of the shoulder joint. So this is commonly found, I think, in the shoulder arthroscopy, where the posterior port,
True. Yeah,
yeah,
true.
it creates a problem during the insertion. There will be tachy, and in the post-op period there will be pain, while the rest of the joint would be painless.
Yeah, we'll try doing that. Yes, I think that'll be a good suggestion. Yeah.
So, Dr. Ritesh,
Ritesh, tell me, how are you?
just amazing presentation, sir.
Thank you so much, everybody.
Sir, just a query. You told that in the intertruncal, you just go aim at the corner, right?
Yeah.
Sir, once you have injected and split open that
Yes.
gap between the two trunks,
Yes.
If we, is it not
Maybe you can advance. Maybe you can
yes,
advance your needle tip.
yes,
Yes, you can do
yeah,
that. So any hypoechoic shadow, Ritesh, which opens up, like you can advance your needle tip very cautiously. That is true. But having said that, Ritesh, in many of these brachial plexus dissections, we find the neural interconnections between one trunk and the other trunk.
right,
And
sir.
we are really not sure about whether these are neural elements or they are non-neural elements. And
Okay.
we have already injected local anesthetic to a certain extent. We are not able to neurostimulate and try to find whether there are any neural elements between the two trunks or between the two fascicles, major
Right,
fascicles,
right, sir.
like the C5 and C6. So that is the big question. So maybe the next time when we insert a needle, we don't inject, we try to go in between the two fascicles with a neurostimulation with very low current, maybe 0.4 milliamperes, and try to ascertain whether there are any neural elements. But I'm not sure whether it would really help in any ways.
Okay, sir.
But we have to be
Okay.
careful again, Ritesh. Even after
Right, sir.
injections, if you traverse, there are some neural elements, some twigs from one to the other.
Okay, sir. Okay. Okay, sir. Thank you. Thank you, sir. Thank you very
Thank
much.
I can see a raised hand, but I can't see the name.
I was only there. I
Yeah.
asked.
Okay.
Yeah.
Okay.
Thank
Yeah.
you.
English person, Ritesh. I think we are done.
Yeah. All the questions are answered. Thank you, sir. It was an amazing presentation, and looking forward for infraclavicular and other parts of the book.
Yeah, so infraclavicular axillary will make it a bit short, so half an hour. So then we can have some questions.
Definitely, sir.
So maybe Sangamitra can let me know when we can do this the next month.
Right.
Whenever
Sir,
there is time, you let me know.
at your convenient time. We are okay with
Okay,
it.
no problem. Yeah.
Yes, sir.
Thank you, sir. Sangamitra, anything
Thank
from
you very much.
No, thank you so much, sir. And
Thank you so much. Thanks everybody. So we sign off. Yeah.
yes, sir, please.
Yeah.
Thank
Thank
you, sir.
you.
Good night.
Thank you. Good night. Yeah.